Hey, it's me, Ask Nursing Foma, and today this video is all about everything you need to know about case management. And before I get started, I just want you to know that I am a holistic nurse coach and I help nurses start businesses by building sustainable digital courses by leveraging what they already know as a nurse and packaging it in a really digestible introductory course that they can easily charge $100 or more, using social media to attract clients to purchase these courses. And the reason I feel this way is because I feel nursing is getting to a point where if you really desire to be treated well and not feel abused by your employer or by your coworkers, it's really a benefit for you to start bringing different forms of income that doesn't rely on you leaving your house and going to a hospital. So when you have other outlets to bring in income for yourself, then you can start demanding better treatment where you work because you have the confidence that you can still provide for yourself with or without the hospital. But a lot of you are reaching out to me and you're asking me, Foma, I want to know more about case management because I'm tired of the politics and I just want to still use my nursing background in a different way. And I will tell you what you need to know about case management, and I also will tell you why I'm not really the best advocate on helping nurses transition out of bedside to case management, even though I've done a video in the past about it, and I'm going to talk about that. So I'm doing my best to make this video short because I like videos I get straight to the point. So when it comes to case management, if you're not really aware of it, it is a nurse who usually has 1 to 2 years of experience in acute care, working in a hospital setting, because you do need to know the clinicals and the disease process and the normal occurrences that should happen when a patient is hospitalized, because now you are the person who is between the insurance, the physicians, the family, and the patient. So you're like the liaison between all these different departments. And so once you have a strong foundation in acute care, you know how to deal with your patients, then it's all about knowing when a patient's appropriate to leave, meaning being discharged. Do they need to go to acute rehab facility? Do they need to go to a skilled nursing facility? Do they need home health? Do they just need to go home with equipment? Or do they just need to go home? And so by you being a strong nurse in an acute care setting, you can understand like the different levels when it comes to transferring a patient or leaving a patient. Now, sometimes the patient, the medical team as a collective will feel like the patient is best for them to go home because hospitals are all about keeping the patients the least amount of days so they can get reimbursed, and also prevents, other health issues from coming. So if the patient goes in for pneumonia and they contract another disease process, like now they have to foot that bill, if that makes sense. So hospitals are all about, once they solve the initial reason why they came to the hospital, they want to ship you out. Now, when you're a strong case manager, you start advocating appropriately when you feel that patients could benefit from additional days. And so when you have strong nursing skills, you can understand, like looking at the clinical labs, looking at the patient's health history, that they've been in the hospital back and forth several times, or specifically in the past 30 days, you can advocate, hey, I recommend we do this. And then our discharge plan includes them going to a long-term care facility or a skilled nursing facility, and also give time to explain to the family, like, this is what you do when this happens. Don't come straight to the ER, go here, or get, let's connect you to the home health agency. They can do these types of services at your home. You don't need to come into the hospital and expose yourself to others more serious illnesses. So that is pretty much what case management is. Now, on the flip side, case management is not a walk in the park where just because you're not passing medication anymore, or you're not doing clinical skills like cleaning patients up and doing blood draws and preparing them for surgery and doing all those things, case management is still stressful. And because a lot of different nurses, from the ICU to the tele to the med-surg to the surgery, because they think because we're not doing direct care, our job is just easier, but it's not. It's stressful in a different way. When you're in direct care, you have these patients maybe 1 or 2 days. In case management, you can have a patient, depending on what type of assignment you have, for a whole month, and then their family is always calling you for the littlest things. The nurse on the floor is calling you for the littlest things. If they don't know where the patient's shoes are, if they don't know where the patient's wallet is, if they can't if they don't have strong boundaries to deal with the family or the doctor, they'll call you instead of calling the house supervisor or the hospital security. Because when I think of case management, it's like whatever I can't deal with, call case manager. And our role is just to be sending updated clinical reviews to the insurance so the hospital get reimbursed. We're like the financial connect, right? We help the hospital get reimbursed for their services. You're also working with the other healthcare facilities and providers to coordinate their discharge plan. And you're also coordinating with the family, explaining on what the process is, what they need, and then helping them connect with the doctor if they have more questions. But when they start asking you to do things that's not in case management, meaning dealing with interpersonal communication with family, not understanding what's going on, it really can bog your day down, because you can have a caseload of upward from 18 to 20 plus or more patients depending on what type of staffing you have in your department. And case management is a high turnover department. There's always people like coming and going because it's a high stress. You're dealing with especially when you're floating, when you have one assignment, you do a lot of legwork, you got a lot of things done, and the next day you're assigned a totally different set of patients. So all the work you did for yesterday is making it easier for the case manager coming after you, but then you're catching up depending on what type of quality of work that the case manager that was working your cases before you determines what type of work you're going to be doing. And so in case management, you really acknowledge which case managers do their job and which ones just skate by and do the bare minimum. And that's what makes case management very stressful, because it's very common that the leadership in case management, they're not really trying to help and be your advocate. Their goal is to get things done, and that's it, right? And so when they're short staffed, they're going to actually do extra shifts. But when you need someone to cover you, they're not going to help you, and blah blah blah. So it's just like a lot of politics, and it's a very high stress position because you're dealing with money. Every time these patients are here, everyone's asking, why are they here? Why are they here? They don't care that you're catching up. This is your first day with the patient. They just care that this patient's been here for 18 days and this patient's still here. They don't care that all the skilled nursing facilities are declining the patient because they feel this patient is going to be a dump. The families, they're stressed out. They don't care this is your first day. They just understand that the case manager they spoke with before you, the day before, didn't give them the type of response that they're expecting. So it's a very high stress, and you have to be really good with boundaries. You have to be really good with boundaries with your colleagues, because what I've noticed is the case managers that have been there the longest, the most seasoned, some of them, not all, but some of them are really rude because they're not happy with themselves. And instead of checking that and dealing with that on their own, they spew that garbage to you, especially if you have like a very optimistic and you're trying to do your best to make a difference. The more senior case managers, they're going to be rude. There's just like a lot of politics, and it doesn't go away entering case management. So that's one thing that I want you to know. Case management is not an escapism from nurse burnout. It's just a different type of stress. So if you don't want to do physical labor but can still deal with the mental stress, then go into case management. Now that I discussed to you what case management is, and then if you notice, I didn't really break down like what do you do in a day and blah, 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 because I've worked at several different hospitals, several different types of healthcare systems, and it's very individual. Like, the longest you have 1 to 2 years of experience in acute care, they can train you on how they do case management. You're basically faxing clinicals to the insurance. You're explaining to them what the plan of care is. You're explaining them like what the physician's plan is, what level of care they are. You know which patients need to go to a med-surg floor, to a telemetry floor, ICU floor, just based off being on the floor. So when you have patients who no longer meet the criteria of med-surg, you'll bring that to the house soup or tell the doctor to change their order so they can be transferred to a different unit, because now they're presenting with new symptoms that needs to be on a level with a floor with higher acuity, or vice versa. If they're on ICU and they don't meet criteria for ICU, you'll speak to the doctor to downgrade their medical level of care to a unit that's either a step down or med-surg, right? Because they don't need that amount of services. So the same skills that you practice on the floor is the same things you do in case management. The only difference is just knowing the nuances of doing clinical reviews, and literally within a month or so, you will understand these things. Now, that's why I don't go into deep detail about like what case management is, because I can tell you how it is at this hospital, then you go to another hospital, they say we don't do it this way. We don't do reviews every day. We just do one review for this type, and we do it's just like very customized. But the thing is, do you have common sense? Do you have strong boundaries? Do you have confidence in yourself? Do you care about people, and do you think outside the box, right? So what I feel is best, because I'm not really a strong advocate for working for people, because I've never really found a place of employment where I felt valued, like I felt my home. I've never really found a hospital where I felt at home, where I felt like all my gifts and talents were appreciated. So I've always found myself, floating from, I worked at really great hospitals, or prestigious, they all have their pros and cons. I worked at jobs where I was paid well, 3 12-hour shifts per diem. I travel, I've done it, but I've never really found my place within nursing. I've started med-surg telemetry. I did behavioral health for a little bit, and then case management is the longest specialty that I've done consistently. And even with case management, I don't feel like it's my happy spot. It was something that I could tolerate, make a living for myself, but it wasn't something where I'm like, this is my life calling to be a case manager, And so I feel to be an integrity that I'm not doing you a service by just talking about getting to case management when I don't even believe in it as much as like the best option. The best option for you is wherever you are in your nursing, stay there. And while you're doing that, build a course that's simple, that's digestible, that you can charge $100 or more. And what I mean by that a course could just be you doing a video on a common question that people ask you, or you see on social media people ask, and you already know the answer. If you've already excelled in this in your personal life, and you can add your own little spin to it. You get on a recording and you do something for 30 minutes to an hour. You upload it on a platform that you can provide a link to people and they pay you, or you can just upload it onto your Dropbox or Google Drive and give them a PayPal link and charge them $100 or more. So when you do that, because you're on social media, right? A lot of us are on social media. You're watching me on social media right now. We can just share our lives and explain what worked for us. And then because we have a course, we can say, hey, if you want access to this course, you can DM me, I'll provide you the link to pay me, and then I'll email you the link. Or you can get more fancier when you start getting a lot of interest or inquiries, where you can invest in membership platforms where you upload the training and they allow you to integrate a payment processor so people can automate, so you can automate things. So when I did this way back in 2017, it was really simple for me. The coach that I had told me, just make it really simple. Just create a course, upload it on your Google Drive, and just give people a PayPal link, right? So I gave people